everyone, hope you all are doing great. So today we will be studying about the antiarrhythmic drugs. So here is the list of some antiarrhythmic drugs that we are going to cover in this video. So first let's understand what is arrhythmia. Arrhythmia is nothing but a condition that is generally an alteration in the normal sequence of your electrical impulse rhythm that leads to the contraction of myocardium. Now, generally, these drugs are manifested when there is abnormality in your rate, in the rate of heart or site at from which the impulses are originating or the conduction through the myocardium. Now, as we all know, the rhythm of the heart is normally determined by the pacemaker site, that is the SA node, which consists of specialized cells that undergo spontaneous generation of action potential at a rate of 100 to 110 action potential beats per minute. Now, when this intrinsic rhythm is strongly influenced by the vagus nerve, okay, well, this is one of the cranial nerve which overcomes the sympathetic system at rest. So this vagal tone brings the resting heart rate and down to the normal sinus rhythm, and this normal cardiac rhythm is controlled by the pacemaker of heart or the SA pacemaker activity of your SA node. Okay, so generally, why do we need arrhythmia drugs or antiarrhythmic drugs? This is because for the abnormal or irregular cardiac rhythms, heartbeats can occur when the SA node fails or functions normally. Okay, or when other pacemaker sites, example, ectopic pacemakers trigger depolarization, or when there's a dysfunction caused in the conduction pathway. So now this is the normal conduction contraction action potential duration I have shown you, where there is this entire thing is one heartbeat. Okay, and here we need to understand that the action potential duration is divided into 5 phases. Phase 0 represents the depolarization or reversal of transmembrane potential. 1 to 3 represents the different stages of repolarization. Okay, phase 0 is depolarization, 1 to 3 is repolarization, and the 4th stage is nothing but the resting potential RP. Okay, so accordingly to the this conduction or these changes, there are the drugs prescribed to the arrhythmic patients. Okay, so you just need to remember that phase 0 represents depolarization, 1 to 3 represents repolarization, and 4th phase is nothing but the resting potential. Here I have just explained you all in brief what is happening in phase 1, phase 2, phase 3, phase 4. So we'll just take a quick thorough cover, okay, and I hope you have completed this in your HAP. So in phase 1 there is a sodium influx, so we will need a sodium channel blockers. Phase 2 there is an efflux of potassium that balances influx of calcium. In phase 3, that is again your repolarization phase, that is again having the efflux of potassium, and from the cell it restores the membrane potential to normal potential levels. And phase 4, that is nothing but the resting pump or resting potential. There is involvement of sodium potassium ATPase pump that restores ions into their proper local concentrations. Let's move ahead to the pharmacological intervention. Now here it is all the HAP part, that the Purkinje fibers have a branch into a network interlacing fibers. Then there is a longer conduction of time that allows to the tissue to read. You can just have a read on this, so this is not very much important. We'll just now focus upon the classification. So antiarrhythmic drugs can be classified into 4 categories, that is your class 1 sodium channel blockers, class 2 that is your adrenergic blockers, class 3 that is your adrenal potassium channel blockers, and class 4 that is your calcium channel blockers. Here all the drugs used are the blocking agents. Okay, so let's study in detail. So first is the sodium channel blocker, acting as a local anesthetic. Now local these class 1 drugs also as a local act as a local anesthetics, which acts on nerve and myocardial membranes. It slows the conduction by blocking the sodium channels and inhibits the phase 0. Phase 0, that is nothing but the depolarization phase of the action potential. Now these class 1 antiarrhythmic drugs, they decrease the maximal rate of depolarization without changing in the resting potential. They increase the threshold of the excitability, which is important as a drug. The effective refractive period is also increased, and there is a conduction velocity and decrease in the spontaneous diastolic depolarization in pacemaker cells. Now, the important point here is that there is a decrease in the diastolic depolarization that tends to suppress the ecotopic foci activity. That is, there is the site is not deferred in this. There is a suppression of the ectopic foci. Okay, and there is a prolongation of refractive period, which tends to abolish the re-entry of the arrhythmias. Arrhythmia is nothing but the slow conduction of heart or the no, abnormal heart beating. So when there are the when the person or the patient is prescribed with sodium channel blockers, the refractivity period is increased, which tends to decrease the re-entry of the arrhythmia. Okay, and these antiarrhythmic drugs have low affinity at R channels, receptor channels, but relatively high affinity for A and I channels or both. Okay, now the action of class 1 local anesthetic type of antiarrhythmic drug is pH dependent and may vary with each drug. As I said कि जो class 1 के drugs है for your, that is a sodium channel blockers for your antiarrhythmic drugs, these drugs are also the local anesthetic types. Okay, and the pH is very dependent, and that may vary according to the each drug. So generally they are the weak bases, with most of it having a pK values ranging from 7.5 to 9.5. This is very important asked in your MCQ type of questions. Now we know at physiological pH 740, these bases exist in the equilibrium mixture consisting of both the free base and the cationic form. Ionizable drugs such as lidocaine, generally used in the dentistry purpose for as a local anesthetic, have stronger electrophysiological effects in ischemic rather than normal myocardial cells. So why? So this can be asked in your justification types of questions. Now this potentiation has been attributed in the part to increase the H concentration, hydrogen concentration, and as there will be increase in the hydrogen concentration, there will be acidosis increase, and due to this, as there is a acid present more in more proportion, the sodium ion channels occupy the protonated form of the antiarrhythmic region. Okay, and nevertheless, obviously, when there will be the increase in the acidity, there will be the effect of pH will be slightly changed, and the drugs can become more complex. So both cationic species have been proposed as active form of some drugs. The uncharged form of the sodium channel blocker can penetrate directly from the lipid phase to the surrounding cell membrane to block the channel. Now we have the first drug, quinidine. Quinidine is widely used for the acute and chronic treatment of your ventricular and supraventricular arrhythmias, especially during the supraventricular tachycardia. Okay, now quinine generally, which is found from the cinchona bark, Cinchona officinalis, okay, and which is a diastereomer of your quinine. So this is the structure of quinine, which consists of a quinoline ring, a cyclic amine, a alkene, and a secondary alcohol. I'll just show the structure properly. Yeah. So this is the proper structure of quinidine, okay, which has a quinol ring, cyclic amine, secondary alcohol, and a alkene present. and this is generally extracted from the cinchona bark, okay, Cinchona officinalis, and alkaloid. Okay, structurally, this it consists of a it can be asked. It consists of a quinine ring, a bicyclic quinine nucleide ring and system, and a hydroxymethylene bridge. And generally, it reveals two basic nitrogens. That is a quinine nucleidine nitrogen with a pK of 11, and obviously it has a basic character. Okay. So the metabolism is generally they are the hydroxylated derivatives which pass through the first fast OD methylation or at the quinine nucleidine ring through the oxidation of the vinyl. One third activity is possessed by these metabolites, active metabolites generally. So you know this is the quinidine structure. When there will be O demethylation, there will be the formation of oxydihydroquinidine, which gives the one third of the activity. Side effects are gastrointestinal disturbances such as your nausea, diarrhea, vomiting, etc. Then we have the other local anesthetic antiarrhythmic drug, that is procainamide. Now this procainamide is effective in the treatment of several types of cardiac arrhythmias. Its actions are similar to that of the quinidine, yet procainamide can be effective in patients who are unresponsive to quinidine. As quinidine, there are several patients that do not respond to the quinidine. So in such case, the local anesthetic procainamide is given. Now you can just correlate with the structure. This is the structure of your procaine, in which only this oxygen is replaced with the amide group here. So this is the structure of your procainamide, okay, which is derived from procaine anesthetic procaine itself. Okay, it is the ester or the bioisoster of procainamide. And it is administered intravenously to produce several significant short-lived antiarrhythmic effects. Unfortunately or considerably, this also causes the CNS toxicity in addition to short duration. So there is a very limited use of this. Okay, and moreover, the procaine is not active orally because it has a short duration of action. So it is either given chemically or plasmaesterase hydrolysis. Okay, and the logical modification of this molecule was the isosteric replacement of the ester group with an amide group. Okay, simply the procaine say procainamide banaya. There was an exchange or the replacement of ester. So this can be produced orally, while the procaine cannot be produced orally, which is resistant to both again enzymatic and chemical hydrolysis. Then its metabolism. Now the metabolism of procainamide is very important. We remember when the procaine was metabolized, it gives PABA, para-aminobenzoic acid, which is responsible for several allergic conditions. But here the procainamide gives NAPA, okay, N-acetyl procainamide in the presence of N-acetyl transferase. Okay, so here there is a acetyl group, so and there is an acetyl transferase present here. So this hydrogen is replaced with one one acetaldehyde group. So it is acesanide. Okay. Then we have diisopyramide, which is orally and intravenously effective antiarrhythmic agent. This decreases the phase 0 diastolic depolarization and decreases the conduction velocity, and this has a vagolytic property. It is used clinically in the treatment of refractive, life-threatening and ventricular tachyarrhythmias. This isopyramide is commonly exhibit side effects of dry mouth, constipation, urinary retention, as it is structurally similar to the anticholinergic drugs. So all the side effects of anticholinergic drugs are possessed by these diisopropamide. You can see the structure of diisopropamide here. The basic structure is same, only the highlighted part is a change here. This highlighted part. Then we move to the class B antiarrhythmic drugs. Lidocaine. Lidocaine we know it is generally used for your dental surgery as a local anesthetics. Okay, and this is also effective in use treating the ventricular arrhythmias. And this is the structure same as the lidocaine or your lignocaine. Okay, and it is given only parenterally, and intravenous route is obviously more common. Now this as similar to the procaine, it is also has certain cardiac effects. Okay, the procainamide was having CNS effect, but it has cardiac effects, but distinctly different from the procainamide or quinidine. Hepatic metabolism is rapid here, okay, and ethylation to yield the monoglycinylate. Okay, now the metabolism of hepatic metabolism is very important, that is occurs in the liver in the case of lidocaine, yeah, where the lidocaine is metabolized to give a active metabolite megax, if you remember. Megax. Megax is nothing but monoethyl glycine xylide, which is followed by the amidase catalyzed hydrolysis enzyme involved. Okay, so this is generally the product, and there is also amide hydrolysis, which gives a minor pathway. And the adverse effects of these are it gives the emetic as well as the um, convulsant properties. So the side effects are generally varied according to it. They can be CNS related, they can be GIT related, okay, or sometimes epileptic seizures. Then we have token hydrochloride, which is an analog of lidocaine. This differs from lidocaine that lacks two ethyl groups. Okay, lidocaine has two ethyl groups. In this, there is no ethyl group. Just rest of the structure is same. You can just compare here. This is the difference, okay, between the tokenide and the hydrochloride. That's why tokenide hydrochloride is the analog, and it's none of the metabolites are active. And this gives first pass hepatic metabolism by the after the oral ingestion. Then we have phenytoin sodium. This produces the as we know, this is also used in the grand mal type of epileptic seizures. It causes bradycardia, which prolongs the PR interval and produces the T wave abnormalities, and the action is similar to that of the lidocaine. And without there is no such adverse intraventricular conduction is there. This is generally important for your supraventricular tachycardias, which is generally caused due to the digitalis intoxication plaque. Okay, digitalis officinalis is again the cardiac glycoside, we can say, which is found from the digitalis plant. Then we have maxilitine. This is given again either orally or intravenously. Structural difference, you can just compare from the lidocaine what are the structural differences. Okay, as we have seen in the torcanite, it is similar to that of the torcanite. Okay, that's why it is again an analog of lidocaine, and it possesses a xylene moiety which is otherwise chemically different. Rest, it is not subjected to any kind of ether or hydrolysis. Okay, and the two metabolites are p-hydroxy maxilitine and hydroxy methyl maxilitine, which are not pharmacologically active as an antiarrhythmic agent. Okay, moving ahead to the lorakinate. Lorakinate is nothing but the class 1C antiarrhythmic drug, okay, and which helps to restore again the normal heart rhythm in patients with premature ventricular contractions and ventricular tachycardia. So this is the structure of your lorakinate. This is completely different from the other local anesthetic type of your antiarrhythmic drugs. So you need to practice this. Okay, so we'll now see about the general, what are the general difference between the class 1, class 1 antiarrhythmic drugs, which is further subdivided as class 1A, class 1B, and class 1C. Now, all we know first, it is sodium channel blockers. Class 1A shows intermediate rate of dissociation from the sodium channels, class B shows rapid, and class C shows slow rate. Then class 1 shows phase 0 depolarization, similar to that class 1C shows phase 0, but 1B shortens the phase 3 repolarization. Okay, this is the difference, this point of the repolarization. This is the difference of this. And again, it is the class 1A, and class 1A is prolongs the action potential duration, and class 1B shortens, and there is no role in the action potential for class C, and both class 1 and class C are responsible for slow conduction. And the other difference is that class 1A works on your atrial and ventricular tissue both, but the class 1B and 1C are used for your ventricular tissue only. Drug examples are the quinidine, procainamide, and diazopropamide for your class 1A, lidocaine, phenytoin, tocanide, and mexiletine for class B, and enacanadine, propafenone, morizicine, phylakinide are for your class 1C. So this is the classification for your sodium channel blockers. Sodium channel blockers, that is class 1 antiarrhythmic drugs. Then we have class 2 adrenergic blockers, in which we have the sotalol. Sotalol is generally a dual acting, which is used in your class 2 as well as class 3, that is the potassium channel blocker. Okay, due to the similarity of its cardiac effects, and due to the chiral center, because of which it is marketed as a racemic mixture, because its enantiomers has two antiarrhythmic drug of classes, both, as I said, blocking and beta blocking agents, adrenergic, and potassium channel blocking agents. This is due to which the beta adrenergic affinity study to 60 times lower and produces different effects on the heart. Now, in this, the sinus node is associated with slowing of the sinus heart rate, whereas the beta adrenergic blocker contributes to decrease in heart rate observed by the L-sotalol. So, generally, this is marketed preparation of the racemic mixture. It is characterized as also class 3 antiarrhythmic drug because it prolongs the duration of action potential and increases the effective refractivity period. Class 3 drugs are amiodarone and the brightilium, and also you can just include the sotalol, that is a repolarization prolongators. This generally acts on the phase 3 of the action potential by blocking the potassium channel, in which the beryllium is a prototype drug of this class, and amiridione is also used, which prolongs the action potential. And the next class, that is the next is one more class you have, that is calcium channel blockers, which you can refer from the other hypertension or diuretics type of. Okay, so calcium channel blockers drugs you can just refer from other, that is verapamil, diltiazem, nifedipine, nimodipine, felodipine, whatever drug you can just prepare for the classification part from any of your uh, chapters which have CCB in it. Okay, so this is the structure of amiodarone, which is was developed as an anti-anginal in the coronary vasodilator, but it has also shown the effects of antiarrhythmic. Okay, that is especially in the life-threatening ventricular arrhythmias. So it is a very majorly used drug and a very useful drug. Now its severe toxicity is making the drug as a last choice. So as I said, the Brightalium is used as a prototype drug, okay, which is initiated in the hospital setting.